All right, well, welcome everyone to this month's Evening with Genetics on the topic of monogenic diabetes. So what I'm going to do is I'm going to introduce our three speakers and then I'll let them get started. So Dr. Jennifer Posey is an assistant professor in the Department of Molecular and Human Genetics at Baylor College of Medicine. In her clinical practice, she sees patients in the adult genetics clinic at Baylor McNair. Dr. Posey's research interests lie in the relationship between a person's genetic information and their health, and how this information can be used to develop more personalized treatment approaches. Dr. Posey works with the Baylor Hopkins Center for Mendelian Genomics, the Undiagnosed Diseases Network, and the Rare and Atypical Diabetes Network Consortia. She is the lead PI for the new Baylor College of Medicine genomic research to elucidate the genetics of rare, also known as Gregor, research program. Dr. Mustafa Tosur is an associate professor of pediatrics in the section of diabetes and endocrinology at Texas Children's Hospital and Baylor College of Medicine. He received his initial medical training and Doctor of Medicine at Hacettepe University in Turkey. He completed his pediatric residency training at University of Texas Medical Branch in Galveston, followed by his pediatric endocrinology fellowship training at Baylor College of Medicine and Texas Children's Hospital. He then joined the faculty at Baylor College of Medicine. His research efforts are focused on better understanding of childhood diabetes in the context of its tremendous heterogeneity. Specifically, he is interested in the role of genetic factors, micronutrients, and metabolic disturbances in childhood diabetes. Relevant to today's session, he has been working on optimizing MODY detection in diverse pediatric populations in Houston, Texas, and recently published some of his work in pediatric diabetes. Dr. Ruchi Gaba obtained her medical degree from University College of Medical Sciences in New Delhi, India, followed by residency in internal medicine at University of Alabama, Birmingham, and then fellowship in endocrinology, diabetes and metabolism at Baylor College of Medicine, and has been faculty at BCM since 2015. Her clinical expertise include evaluation and treatment of patients with atypical diabetes, like ketosis-prone diabetes, and maturity diabetes of the young, or MODY. She is actively involved in innovative and cutting-edge clinical research in the field of diabetes. She has been working on careful phenotypic characterization of novel forms of type 2 diabetes and has presented her work in the form of abstracts and poster presentations at national meetings like American Diabetes Association and Endocrine Society. So welcome to our speakers, and I'll sign off to Dr. Posey to get started.
Thank you so much, Liz, and thank you for the opportunity to speak today. We're all thrilled to be joining the Evenings with Genetics. So I'm going to start with a little bit of a primer on genetics and monogenic diabetes. And as a geneticist, of course, genetics is near and dear to my heart. For those of you who attend these Evenings with Genetics with some frequency, you may have heard of some of these concepts already, but I'm really going to focus on talking about them in the context of monogenic diabetes for today. So to start, what is monogenic diabetes? When we talk about this form of diabetes, it's not what we call type 1 diabetes or what we call type 2 diabetes. It's actually a distinct form, or I would argue even multiple forms of diabetes that are caused by a genetic change, what we used to call a mutation, in a single gene. And this is what makes them different from type 1 and type 2 diabetes in some regard. So when I talk to patients about monogenic diabetes, particularly when I'm diagnosing someone with monogenic diabetes, one of the first questions that they typically want to know is, what are the health impacts? What does this mean for me? And it turns out that there are many different genes that can cause diabetes. And each type of diabetes, each type of monogenic diabetes can be a little different and have different health impacts. And so I'll give you a few different examples of that right now. And then Drs. Gaba and Tosur will provide a little bit more detail for a few of the more common examples in their talks. So some types of monogenic diabetes cause only a high diabetes risk. And what that might mean for a person who has a genetic change, which I'm showing here with this sort of red lightning bolt in a gene. In this case, you can see some blue DNA. What this means in this particular case is that an individual with that type of genetic change in that particular gene has a much higher than general risk of diabetes during their life. There's a very good chance that they will go on to develop diabetes. And for many of them, this might happen even if they're keeping a healthy lifestyle. In contrast to that, there are other individuals who may have a form of monogenic diabetes that causes both a risk of diabetes as well as, for example, kidney cysts. And so this would involve a different gene, a different genetic change, and they would have more than simply the diabetes risk. If we were seeing them in my clinic, we would talk about how we needed to watch their kidney function. And so an example of this is one form of MODY, or maturity onset diabetes of the young. And this particular form of MODY is caused by genetic changes in a gene called HNF1B. And what you can see here in this particular diagram of a kidney is that the individuals with HNF1B MODY will actually have little cysts in their kidneys. These can grow and they can increase in number over the course of a lifetime. And for some people, this can impact the kidney's ability to function and filter blood and to do its job. And so for these individuals, in addition to monitoring their blood glucose and thinking about their diabetes, we're keeping an eye on their kidneys and their kidney function to make sure that we keep their kidneys as healthy as possible throughout their lifetime. And I'll contrast that with yet another example. There are some forms of monogenic diabetes that might cause an increased risk of diabetes, but also hearing loss and heart disease. And these involve different genetic changes and yet different genes as well. And I'll show you an example of the class of condition that can cause these types of health risks. And these are generally, this particular condition or class of conditions is called mitochondrial disease. What's important to know about mitochondrial disease is it occurs when an individual's mitochondria don't function correctly. What I've shown here in the center of this diagram is a picture of a mitochondria. It's actually kind of been cut in half so that you can see into it. And what the mitochondria do, they're the powerhouse of the cells. And so they make important energy derivatives, in this case, what we call ATP. It's very important for many of our different organs to function. And when the mitochondria are not functioning correctly, people can have a variety of different health risks to different organs. And so, for example, they can have problems with the function of their pancreas. This can lead to diabetes. They can have problems with their blood and their blood cells, problems with their hearing, problems with how their intestines function to move kind of food and food products along. They can also have problems with how their brain functions. They may have seizures, for example, or difficulty maintaining their balance, or they may develop dementia. Some of them will have skeletal muscle difficulties, such as weakness or fatigue. Some of them can have heart problems, and these can be either an electrical disturbance of the heart or a functional problem with the heart and its ability to pump correctly. Some will have problems with their vision, with their eyes, some with their liver, and then some also with their kidney and their kidney function. Many individuals with mitochondrial disease will have a combination of more than one of these different things. So you can see combinations of diabetes with many of these other organ systems being involved as well. So these are just a few examples of some of the different flavors of monogenic diabetes and how they can appear and impact a person's health. And so this brings me to an important question that many people will ask me in my clinic, which is, why is genetic testing important? If you think that I have a monogenic form of diabetes, why do we need to do the genetic testing to investigate that further? And there are a couple of reasons for this. The first is that when we can identify the exact form of monogenic diabetes that a person has, it tells us whether or not they're at risk for other conditions. Do we need to watch them just for their diabetes risk, or do we need to also think about their kidney health, their hearing, their heart health, etc.? Identifying the genetic cause for a person's diabetes can also tell us whether other members of their family might be at risk. And so I want to talk just a little bit and review a few basic genetic concepts. So our genetic information is stored in chromosomes, and you can see here sort of a nice, almost cartoon-like depiction of the chromosomes as these small X's. And so our cells contain this genetic information in the nuclei. And when you look at the chromosomes under a microscope, you can count them, and you'll see that in humans, in all of us, we have 46 chromosomes. The first 44 are pairs. So we have one copy of each chromosome from our mother and one copy from our father. And so, for example, in the upper left-hand corner of this orange box, you can see 2 chromosome 1s. One copy was from this person's mother and one from this person's father. The same for chromosome 2 and 3, etc. The last 2 chromosomes are the sex chromosomes. Women will have 2 X chromosomes and men will have an X and a Y chromosome. And so this is what these look like under the microscope. If you dig even more deeply into looking at that genetic information, what you see is that the genetic information is actually organized around these orange histones. And if you were to unravel those orange histones, what you would see is the DNA itself. And when we look at the DNA, when we unravel it like that and start to look at the sequence and the structure, we can see sections of the DNA, or the genetic information, that actually encode our genes. And the genes largely hold the instructions for how our cells are formed, how they function, how our bodies are formed, how our organs are formed, and how they function. In us, in humans, we actually have about 20,000 genes, and these genes largely encode for proteins, and those proteins are what do the work of making us, making our organs, ensuring those organs, our cells, et cetera, are functioning the way that they are expected to. Of those 20,000 genes, there have been at least 200 that have been associated with different forms of monogenic diabetes. And so Drs. Gaba and Tosur will tell you about several specific forms of monogenic diabetes that are among some of the more common forms. But I want you to be reminded of the fact that there are actually many, many different forms of monogenic diabetes, and many of these include additional organ system involvement. And so they're much, much more even than the diabetes alone. When we want to determine what type of monogenic diabetes a person has, we will do a test called sequencing, where we're actually reading the sequence or the code of the genes. And so if you were to, again, take that chromosome and unravel it, you would see a sequence that looked much like this. And in many ways, this is very similar to opening up a book and reading the words or the letters within the book. And so you can think about our genes as chapters within a book of information. Genetic sequencing, where we read those chapters with the genes, can identify genetic changes or genetic differences that may cause the gene to not work properly. And so when we're doing genetic testing, or when we're doing sequencing, this is exactly what we're doing. We're reading that book and we're looking for genetic changes that might cause the gene to not function the way we'd like it to function. And so this is the type of testing that we do if we think that we are seeing someone who may have a form of monogenic diabetes, where we want to do testing to confirm that diagnosis to know which type of monogenic diabetes it is, and then also to find out who else in the family might be at risk. That type of genetic testing, when we do it, is usually a blood test. Sometimes we'll also use saliva. It kind of depends a little bit on the laboratory that's performing the testing. And the sequencing will focus on the genes that are associated with monogenic diabetes. And so it's often what we call a panel genetic test. And it could be a panel test that focuses on the 3 or 4 genes that are most commonly associated with monogenic diabetes, or it could be a much, much larger gene panel test. And there are a variety of things that go into making that decision about exactly which test to order for someone. So I want to move on just briefly and talk a little bit about who else in the family could be at risk. How can we figure that out? So when we know whether a condition, in this case monogenic diabetes, is what we call dominant or recessive, this can help us determine which other members of the family could be at risk. So I wanted to walk you all through autosomal dominant inheritance and then autosomal recessive inheritance. There are other forms of inheritance, some of which can sometimes be seen with diabetes. For the purposes of today, and much of what Dr. Gaba and Dr. Tosur will also be talking about, the diabetes will either be dominant, usually dominant, and occasionally could be recessive. And so I'll use these as examples. So in this case, when we're talking about an autosomal dominant condition, and this is true both for monogenic diabetes and other genetic conditions, I want to remind you, going back to that idea that everyone has a pair of each of their chromosomes, so 2 copies, one from their mother and one from their father. In autosomal dominant monogenic diabetes, a person will have 1 copy of the gene that has the mutation or the genetic change, and 1 copy of the gene that does not have any mutation. And so here I've shown you an individual in blue who's affected with monogenic diabetes. And that single copy of the gene with the genetic change was sufficient for him to have monogenic diabetes. If he were to have children with a woman who had 2 typical or 2 normal copies of those genes, so she does not have diabetes, then they would have a 50-50 chance with each of their children of having a child with monogenic diabetes. The reason for that is that every time they go to have a child, the mother would pass on one of these 2 normal copies of that particular monogenic diabetes gene, and the father would pass on either the normal copy or the copy with the genetic change or mutation. And so it would be a 50-50 chance which copy the father passed on. And so that the couple would be equally as likely to have an affected daughter, shown here in blue, an affected son over here in blue, or an unaffected daughter or an unaffected son. And so this is how autosomal dominant conditions work. This means that in my clinic, when I identify an adult who has monogenic diabetes, if it's autosomal dominant, we talk about the fact that each of their children or their future children, if they've not yet started their family, has a 50-50 chance of inheriting this condition and this diabetes risk. I want to contrast that now with autosomal recessive inheritance. With autosomal recessive genetic conditions, in order for a person to have that condition, in order for their health to be impacted, they have to have 2 copies, 2 abnormal copies of the gene. So both copies of that particular gene need to be affected with a genetic change. The way that this typically happens is that those children are most often born to what we call carrier parents, where each parent has 1 copy of the gene with a genetic change and 1 copy of the gene that does not have a genetic change. 1 in 4 times that those parents have a child, the child will inherit the mutation from the father and also the mutation from the mother. The other 3 times that that couple has a child, on average, they will either have a child that inherits 2 normal copies of the gene, or children who inherit 1 mutated copy and 1 normal copy. And so for couples who are both carriers for a recessive form of monogenic diabetes, they have a 1 in 4 chance of having an affected child, a 1 in 2 chance, or a 2 in 4 chance of having a child that is a carrier, and a 1 in 4 chance of having a child that inherits 2 normal copies of the gene and is unaffected and not a carrier. And so this type of information, understanding whether a person's monogenic diabetes is either dominant or recessive, can help us work with couples and with families to understand who else in the family or who else in their future family might be at risk for having diabetes. So with that, I want to go ahead and summarize. I hope what you've taken from my part of the talk is that there are many different types of monogenic diabetes. Each of these is caused by a different gene, and they can involve other organ system involvement or other organ system health problems in addition to the diabetes itself. And genetic testing can be used to determine which form of monogenic diabetes a person has so that we can understand how to watch their health appropriately. But it can also help us and help that individual understand which family members might be similarly at risk for monogenic diabetes. In my last moment, I just wanted to mention that the 3 of us today are currently involved in a research study that's called the Rare and Atypical Diabetes Network, which Liz mentioned at the beginning. And we are interested in understanding additional causes of monogenic diabetes. Of the 20,000 genes that we know we have, right now, the field of genetics understands the medical relevance of only about 5,000 of those genes. We believe that there are additional monogenic diabetes genes that have not yet been studied and understood. And so we're doing research here at Baylor and at multiple sites throughout the United States to understand better what some of those additional genetic causes of monogenic and atypical diabetes may be. And so with that, I'll thank you. And I believe we're going to take questions at the end. So I will go ahead and stop my share so that Dr. Gaba can begin.
Thank you so much, Dr. Posey. It was such a fantastic introduction into the genetics of monogenic diabetes. Diving straight into my talk and also sort of reinforcing what we just discussed, monogenic diabetes is a rare form of diabetes which is caused due to a single gene mutation. So the other common forms of diabetes, which I'm sure all of you have heard about, are usually polygenic. And the usual ones are the type 1s or the type 2s, which are the common terms that you'll hear from doctors when they're giving you diagnoses of these kinds of diabetes. But that's all polygenic, poly meaning multiple, whereas monogenic is due to a single gene mutation. It's a rare form, so only contributes to about 1 to 4% of diabetes in the United States. And then it's predominantly seen in Caucasian populations, but it is reported in other races like, Asian Indians in South Africa. But what is actually happening is that, with that gene change that Dr. Posey talked about, the cells in the pancreas that make insulin, the ability to make insulin, which is basically going to help the body utilize glucose for energy, that ability is reduced or it's altered. And that leads to, high levels of blood sugar, which is called diabetes. Why is it important to diagnose? And I think Dr. Posey spoke a little bit about it, but sort of reinforcing what she said, that the first and the foremost thing is that we don't want for the diabetes to be misdiagnosed. Usually patients with MODY will be misdiagnosed as type 1 diabetes. And then they'll be told that they need to be on insulin forever. So some forms of these MODY or monogenic diabetes could be treated with oral anti-diabetes drugs instead of insulin. And so if you identify this kind of diabetes correctly, then it allows for proper management as the treatment, and then also assessment for risk for diabetes complications, which we spoke about in terms of the kidneys or the heart, which varies with what kind of underlying genetic defect we have. So it allows for that proper sort of assessment of that risk and then treatment. And then certain genetic subtypes can have more, or it's basically called extra pancreatic, because diabetes is caused by abnormality in the pancreatic cells, right? They are not able to make insulin. So certain genetic subtypes can have more problems than just diabetes. They could involve kidneys, the liver, the intestines. And then overall, a better diagnosis or a correct diagnosis will lead to adequate glucose control and then improved health in the long term. And then the most important one, I guess, is that it could lead to earlier identification and treatment of at-risk family members. Because remember, it tends to run in generations. It has a familial inheritance to it. And so in terms of monogenic diabetes, there are two kinds. The first one is the maturity onset diabetes of the young, or the MODY, that I will sort of focus on today. But there's also neonatal diabetes mellitus, or NDM. Now, neonatal diabetes mellitus, just touching very briefly on it, it's again very rare. It's 1 in 400,000 infants in the United States. And again, often mistaken for type 1 diabetes. It will present in the first 6 to 12 months of life. And again, caused by different specific genes and mutations. And there can be two types. So you can either have a permanent neonatal diabetes mellitus, or you can have a transient form which disappears for a bit and then comes back during adolescence for these patients. But how the patients or the babies present is that there's failure to gain weight and grow as rapidly as other infants of the same age and sex. And then these patients or these babies can also present with something called diabetic ketoacidosis. So what happens in diabetic ketoacidosis is that it is a life-threatening condition which is basically produced to the ketones in the body, which, ketones are a byproduct of when there's excessive glucose in the blood that cannot be utilized. And so it's very dangerous for the body. And then appropriate therapy may improve and normalize growth and development in these babies. But now moving on to the topic of interest for us today, which is MODY, which is the maturity onset diabetes of the youth. This is the most common form of monogenic diabetes. And again, most cases you'll see are misdiagnosed. So either diagnosed as type 1 or as type 2 diabetes. And up to 2 to 5% of all cases of diabetes in the United States in people who are age 20 or younger, it contributes to about 2 to 5%. So pretty rare, but important. And it usually will present in childhood or adolescence, but then sometimes it's not diagnosed until adulthood. And the symptoms that you experience or the complications, it could be mild or severe, just depending upon which gene is involved. So the signs and symptoms of diabetes are something that patients will usually present with. With MODY, most of the symptoms are mild and they develop gradually. So there might be no symptoms at first. And then they might have high blood sugar levels for many years before they start to experience any symptoms, and it leads to diagnosis. And the symptoms could be, frequent urination, thirst, it could be dehydration, it could be blurry vision, recurrent skin infections, or recurrent yeast infections. Now, hallmark features of MODY per se is that it usually presents, remember, in adolescents or young adults, so presents less than 25 years of age. And remember, I said the initial form could be mild and they might not need to be on insulin at that time. So it's a non-insulin dependent diabetes, which is diagnosed at a young age. And then there's autosomal dominant transmission, which Dr. Posey explained to us in details that usually, it's more than 2 generations that are going to be involved. And then lack of autoantibodies. So what does that mean? Remember, I keep mentioning about type 1 and the type 2. So type 1 and the type 2 are the most common forms of diabetes, and type 1 usually present in childhood when there's absolute insulin deficiency in the body, and that can make you very sick. Remember the diabetic ketoacidosis we spoke about? So that is usually type 1, and it's considered an autoimmune, auto meaning your own, and immune means antibodies. So you have antibodies that are sort of attacking your own cells in the pancreas that make insulin and causing an inflammation and not letting them function like they're supposed to. So in these patients, in MODY patients, actually, they do not have these autoantibodies. So that's atypical in comparison to like the typical type 1 diabetes patients. And then these patients don't have evidence of insulin resistance. What is insulin resistance? So the type 1 patients we spoke about. In type 2, it usually will present It's an adult onset of diabetes, and the phenotype or the appearance of these patients is mostly obese, or they have insulin resistance. So the defect is not in the production of the insulin, it's rather that insulin cannot act appropriately on the tissues. There is resistance. And so that is the classic feature of a type 2 patient. So differentiating Modi from type 1 is that there's no autoantibodies, and differentiating from type 2, there's no evidence of insulin resistance, and they appear normal. They're not going to be obese. Though let me tell you that these are the hallmark features we're talking about. Otherwise, this disease is very heterogeneous, which means you can have different types of presentations. And that's why I think the misdiagnosis with type 1 and type 2 diabetes happens. Now, in terms of the different kinds of MODIs, there are 14 gene changes or mutations which have been described, and 6 are the top 6 are most well known. But realize that earlier they were described by what gene defect? They were numerically named like MODI 1, MODI 2, MODI 3, but now it's more per the gene change that's happening. And so the most common one is the MODI 3, or which is the HNF1 alpha, which I think Dr. Tosur is going to discuss in details with us. And following that is the MODI 2, or the glucokinase gene change, which causes this kind of diabetes, which I will focus a little bit more about. So let's move on to our clinical case for today. There's a 24-year-old female who presented with fatigue happening for the last few months or so, no significant past medical history. For family history, her mother and sister were diagnosed with diabetes in their 20s, and they were on insulin, and father did not have any history of diabetes. On physical exam, her BMI was 23 kilograms per meter square. BMI is pretty much sort of a marker of basically when we classify patients as being normal or overweight or obese, we use the BMI classification, like which category their BMI falls under, which is the body mass index. That's why it's weight divided by their height to the power square. And then the pulse was normal, it was 84, blood pressure was 126 by 80, and the respiratory rate was 16. So pretty normal vital signs. She was not in any acute distress, no signs of insulin resistance. And the rest of her exam was normal, including her thyroid. And so we looked at her blood work, and her labs showed that the hemoglobin A1C was 7.4%, and her random glucose was 138 milligrams per deciliter. So hemoglobin A1C is a number that basically it's a percentage which tells us how the sugars have been doing in the past 3 months. And a normal hemoglobin A1C number will be less than 6.5%. So if the A1C is equal to or above a 6.5%, then that is one of the criteria that that is used to diagnose diabetes. So for her, it was around 7.4. And the blood glucose was 138, and it should be less than 126. So anything above or equal to 126 micrograms per deciliter is again a diagnostic criteria for diabetes. So she's above the threshold for both A1C numbers and also the glucose levels. And then her other comprehensive metabolic profile was normal. Her total cholesterol was 168. Anything below 200 is good. The high density lipoprotein cholesterol, which is the good cholesterol, was 68. Anything above 50 in women is good, so she was 68. And then the low density lipoprotein cholesterol, which is the bad cholesterol, was around 90. You want it to be less than 100. And then the triglycerides, or that's the fat in the blood, was 82 micrograms per deciliter. Again, the normal is less than 150. So her cholesterol levels, to summarize, look pretty good. And then her C-peptide was low to normal. So what is a C-peptide? And often, you see these lab results if you're reviewing the results of the lab ordered by your doctor. So the C-peptide is basically a lab that is helpful in detecting the endogenous, so it's inside the body, the insulin production in the body. It's just a marker that we use to sort of quantify if the body is able to make insulin or not. So the C-peptide for this lady was around low to normal. And then remember we spoke about the autoimmunity, which is very classic for type 1 patients. So this is just an example of the autoantibodies that we checked, which is called the GAD or the GAD antibody. And then we checked the islet cell autoantibodies, and both of them were negative for this patient. So then why are we thinking of MODY? Of course, this is a MODY presentation and the patient has one kind of MODY. And we're thinking, why did we start to think about this diagnosis? So number one, she was diagnosed at a young age, right? And she did not present in acute hyperglycemic meaning elevated blood sugars. So she didn't have like a crisis or the ketoacidosis presentation. And she was not overweight, not obese. She had no personal or family history of autoimmunity. So that made type 1 diabetes less likely. And then she did have a strong family history of diabetes, which was diagnosed as a young adult. So type 1 diabetes, again, less likely. And her lipid panel was normal. So cholesterol and everything looked pretty good, which remember in type 2 diabetes, you'll see the obese looking patients whose cholesterols or triglycerides will be really high. So then that makes type 2 diabetes less likely in this patient. And so keeping all these points in mind, we thought about MODY, that could be one of the diagnoses for this patient. Now moving on to MODY number 2, which is the glucokinase gene change that Dr. Posey was saying. We don't call it mutation anymore, it's the change. But the GCK gene involvement is the one that's the second most common kind of MODY. And several mutations in the GCK gene on the chromosome 7 can lead to this kind of diabetes. So what is happening is that there's a defect in the expression of this gene, which leads to an insulin secretory deficit. Now, what does that mean? So there's a certain threshold of glucose in the body that causes the release of insulin from the cells in the pancreas. When there is this defect in this gene, that threshold is altered, it's slightly higher. So that leads to a higher fasting blood sugar levels. So the diabetes is really mild because it's only really in the fasting blood sugars, but throughout the day when you're eating your food, which we call prandial blood sugars, are not affected as much because the pancreas or the cells are able to release the glucose, just that it needs a bigger stimulus to do that. And so that's why the hyperglycemia or the elevated blood sugars are sort of non-progressive and mild. The hemoglobin A1C number is usually less than 8%. Remember, 6.5 or above diagnosis diabetes. So it's less than 8% because it's mild. And then the elevated fasting blood sugar we spoke about. So the fasting blood sugar will be elevated, but usually the post-prandial, which means post-meal blood sugars won't be that high. And because the diabetes is so mild, the patients could not have any symptoms and are usually not associated with the typical complications, that are common in other types of diabetes mellitus. And the typical kind of complications are when they could start to affect your eyes, your nerves, your kidneys, or start to affect your heart. So those are not seen. All right. And mostly because this diabetes is so mild, it could be controlled with lifestyle or just diet changes. So that's classic of the GCK gene mutation-related MODY, which most likely our patient had because her picture fitted the criteria. Now moving on to the other kinds, remember I said that the first 6 are more well-known. So there are a total of 14 that have been identified. We spoke about MODY2 already, which is the glucokinase gene mutation. The MODY3 or the HNF1 is the one that Dr. Tosur will be talking to us about. But I quickly wanted to touch base on MODY1, which is also familial and early onset, sort of resembles MODY3. So once we hear more about MODY3, MODY1 and MODY3 sort of go together in terms of when you're suspecting what's going on. And then the kidney involvement, the extra pancreatic involvement that we were talking about is seen in MODY5 or MODY8. In the MODY5, you could have polycystic kidney disease where the kidney has some cysts or fluid-filled spaces, or it could be hypoplasia, whereas the kidneys are not developed as they're supposed to. Some women can have issues in how their urinary or genital tract development happens. So definitely much more involvement than just the pancreas or just the diabetes. And so take-home message from my part of the talk is that we want to suspect MODY in a young patient when they're presenting with diabetes. Remember, it's a hereditary form of diabetes due to mutation in autosomal dominant gene. So it runs in more than 2 generations. There's 90% or more inheritance that happens. And usually patients are not going to be obese or not the typical type 2 looking patient with high cholesterol, high triglycerides, which is the fat in the blood. And they will not have the diabetic ketoacidosis kind of presentation which a type 1 patient could have. And then there's no autoimmunity or those autoantibodies that we discussed about. And it's important to differentiate it from type 1 and type 2 because this kind of disease is missed all the time. It's misdiagnosed. So it's crucial that, somebody suspects it. And these are my references. All right, so I will hand over the baton to Dr. Tosur. I'll stop sharing here.
All right. Thank you, Dr. Gaba, and good evening, everyone. Thank you for the organizer for giving us this opportunity to present here. And also thank you for everyone for making time in the evening. I'm going to talk about MODY 3 and clinical care of MODY in general. So MODY 3, that's also known as HNF1 alpha MODY, one of the most common MODY types together with GCK MODY and MODY 2, depending on the countries, and Europe and United States show some differences. In one place, the MODY 3 is more common. In some regions, the GCK may be more common. And however, the MODY 3, it's the most common form of MODY that results in familial symptomatic diabetes. As mentioned earlier, GCK MODY does not cause any symptoms. And this is caused by the name implies, by a disease causing genetic changes in a gene known as HNF1 alpha. It usually presents with symptoms during adolescence and early adulthood. In the early stages, patients tend to show significant elevation in their blood sugar levels, especially after meals or during an OGTT. OGTT is a sugar loading test that we use to screen for diabetes or prediabetes. And the patients with MODY 3, they tend to get the sugar in their urine even before diabetes onset. Similar to type 1 and type 2 diabetes, we do see diabetes complications in MODY 3 at this similar frequency, and diabetic eye disease, kidney disease, nerve disease, and heart diseases. And key to decrease all these risks is an optimal glucose control. The patients may present in different ages, and the age of onset is partly determined by the genetics. Individual carrying disease-causing genetic changes in HNF1 alpha develop diabetes in 63% of the cases before 25 years of age, in about 79% of the cases before 35, and by 55 years of age, 96% of them, they develop diabetes. And in terms of treatment, first of all, the diet is important for all kinds of diabetes, and it's also important for MODY 3. And the sulfonylurea, this is a pill that patients with diabetes can use, and this type of MODY 3 is very responsive to sulfonylurea. And recently, there is some evidence that glucagon-like peptide 1 agonist, this is another type of diabetes medications used commonly in adults and some children as well. And if all of these treatment regimens are not enough to control the blood sugar, insulin can be used as well in MODY 3. Here, I'd like to share one of my cases that I've seen recently, and which is a typical example for MODY 3. And this is a 13-year-old male and presented with excessive drinking, urination, and some weight loss. His BMI was 87th percentile, and he did not have any acanthosis nigricans on exam. And this is the darkening and thickening on the neck. The medical name is called acanthosis nigricans. and he did not have diabetic ketoacidosis at diagnosis. He presented in a milder way. His hemoglobin A1C was 8.4%. As Dr. Gaba mentioned earlier, levels above 6.5% are consistent with diabetes, and his blood sugar level was 232. And initially, he was suspected to have type 1 diabetes, and he was started on multiple daily insulin injections. They did test for islet autoantibodies, and it was there were 4 different islet autoantibodies, and all of them were negative. Islet autoantibodies, they are used as a marker for type 1 diabetes. So our patient did not have any of those markers. Here's the family history. This is our patient here. The mother was diagnosed with type 1 diabetes at 10 years of age, and she has been treated with insulin since the beginning. And maternal uncle diagnosed with type 2 diabetes at his 30s, and he was treated with pills. It was not clear what kind of pills he was taking, and he died of a heart attack at the age of 38. And maternal grandfather was diagnosed with type 1 diabetes at 30s, and he was treated with insulin, and he died at 69 years of age. And maternal grandma was diagnosed with type 2 diabetes at the age of 22, and she was treated with metformin. And about 5 months after diagnosis, because the patient's presentation and available test results, they were not consistent with type 1 diabetes, the treating physician decided to get a genetic testing done for MODY. And then the 5-gene panel through Athena Diagnostic was done. And in that panel, there was a heterozygous and autosomal dominant disease-causing genetic variant in HNF1 alpha consistent with MODY3. So if you go back to our pedigree here, so our patient now has MODY3, and this is a disease, it runs in families in an autosomal dominant fashion, meaning if you have one affected gene, the person will get the disease. If you look at here, the mom, the patient's mother, who got diagnosed with type 1 diabetes at the age of 10, it is quite possible the mother has also MODY3, and maybe maternal uncle has MODY3, and one of these grandparents, they may have MODY3 as well. And then as you can see, like they got diagnosed with type 1, type 2, which is quite common to misdiagnose MODY as type 1 and type 2, especially if you think about like 20, 30, 40 years ago, and at which time like we did not have much genetic testing availability. 8 months after diagnosis, the patient was taking Lantus, and this is one type of insulin, and 20 units daily, and Novolog, this is another type of insulin, with an insulin to carb ratio of 15, correction factor 50, and target 100. So he was taking about 35 units of daily insulin at this point. Given the diagnosis of MODY3, and I discontinued the insulin for this patient, and then we started on, I started patient on sulfonylurea. This is a pill. We initially started 5 milligram, and then we increased his dose to 7.5 milligram. And this is his blood sugar control on oral medication only. And his average blood sugar, 158, his estimated hemoglobin A1C, 7.1%. And in children, the recommended goal based on American Diabetes Association is to keep hemoglobin A1C less than 7%. So he's almost at goal there. And then this is the the bar showing what percentage of time his blood sugar levels are in acceptable, like normal range. And the goal set by American Diabetes Association is to have in-range blood sugar over 70% of the time. And then this patient was meeting that goal as well. 73% of the time he was in, like, his blood sugar levels were between 70 to 180. So this is a great change, like, for patients, and for this particular patient and his family. Like, if you think about it, this patient used the multiple daily injections, insulin injections, for about 8 months. And after that, like, he was able to control his diabetes just taking a pill per day. And the burden, it cannot be comparable. So here I like to talk about the clinical care of MODY, including the other types as well. And the MODY diabetes is an excellent example for precision medicine. When we talk about the precision medicine, so the one concept is we have a patient population, they have a disease called diabetes. You can either give them the same treatment and everybody gets insulin, or everybody gets metformin, or it is quite possible like that this will work in some patients and it will not work some other. However, if you know the what kind of diabetes your patients have, and whether what kind of treatment, like their diabetes responds to what kind of treatments, then you can give treatment A for the blue group and then treatment C for the red group. And then this way, like the resource will not be wasted, and then everybody will get the treatment that they deserve. Here's a diagram representing the beta cells. Those are the cells making insulin in pancreas. In these cells, there is a channel called potassium channel. This channel helps potassium to go out from inside cell to outside. And then sulfonylurea, it affects this channel, and then it closes this channel, which leads to insulin secretion. So the way it works for many patients, it is mainly through this potassium channel. So let's talk about one by one for the common MODY types. And GCK MODY, as mentioned earlier by Dr. Gaba, this does not require any treatment, and except during pregnancy in some cases. And then diet and healthy lifestyle changes will be more than enough to keep blood sugar under control. And HNF1 alpha MODY, the one I presented earlier, MODY 3, and HNF4 alpha MODY, which is also known as MODY 1, they are highly responsive to sulfonylureas, so they don't need to use insulin, and especially at the beginning, and then they can just manage with the pill. And there's an emerging evidence that GLP-1 agonist, another type of diabetes medicine, can be used in HNF1 alpha MODY. The other MODY type, HNF1 beta MODY, and it was discussed earlier in this presentation, the MODY type which presents with kidney cysts. In this group, they don't respond well to sulfonylureas, and then patients usually require insulin treatment. The ABCC8 and KCNJ11 MODY, and they are also responsive to sulfonylureas, and because they mainly cause MODY by affecting the potassium channel I showed you, and then when they are treated with sulfonylureas, and they are able to keep their blood sugar under control. And this is a newer type of MODY, RFX6 MODY, and which is not included in the common MODY types that Dr. Gaba showed, the MODY 1 through 14, and it does not have any number associated with it. And recently it has been shown that this particular type of MODY is responsive to dipeptidyl peptidase 4 inhibitors. This is another type of diabetes medication. This is also, this can be given as a pill, and which makes a big difference for patients instead of using insulin. And I'd like to leave with a note that, as mentioned throughout these presentations, we know a lot of MODY types, but as time goes, we are discovering more and more MODY types. And with the advancement of genetics and with the better understanding of the heterogeneity of diabetes, especially MODY, and I think we have a bright future ahead with newer treatment modalities for different types of MODYs, including MODY. And I'd like to say stay tuned, and more to come in terms of different treatment regimens. And I'm going to stop sharing, and then I think we will go to questions and answer session here.
Yes, thank you all. That was a great presentation. So we did receive one question in the chat. So how early should we screen kids whose parents have been diagnosed with adult onset diabetes or prediabetes?
Okay, maybe I can jump on as a pediatric endocrinologist. I think we need to keep in mind that like the adult onset diabetes is quite common, that like every 10, one in 10 or even 1 in 9, like they have diabetes. So we cannot really screen, or we don't need to screen all the kids like with their parents with diabetes. I think the most important thing, like if we are thinking about the genetic form of diabetes or MODY diabetes, if parents have a kind of atypical diabetes that does not fit with type 1 or type 2 diabetes, and then their treatment regimen does not fit with those things, and then I think that's the right time to test for MODY. If we are thinking about if the parents have type 1 diabetes, actually there is a way that there are free antibody screening, that those parents can get their kids screened for antibodies. If the antibody is positive, and they can get tested further. If the antibody is negative, that means more than likely they will not get diabetes. And then if it is type 2 diabetes, that's a different, and if the parents have type 2 diabetes, and I think at this time, like we need to look at the what other risk factors a child has, meaning like if the child is the child overweight, obese, does the child have acanthosis, like the darkening on the neck, and if a child has multiple features, then definitely yeah, that child needs to be tested as well.
And I can also mention, so I'm a pediatric genetic counselor. And so one thing that we also think about is GINA, which is a Genetic Information Non-Discrimination Act. So if you were to test children who do not have symptoms of MODY or monogenic diabetes, that could potentially impact their ability to get life insurance or long-term care insurance. And so that's one thing to keep in mind, where if the child were developing symptoms, then it would be important to see an endocrinologist, but testing children without having symptoms could impact their ability to get certain insurance. So one other question. So the acanthosis nigricans is present in my family. What does it mean? How can you get it in the research? Can an entire family enter into the study? So I guess the first question is acanthosis nigricans, can that run through families, and what does that mean? And then interested in, I guess, learning more about the RADIANT study and things like that.
I can take the first part of it. That is, acanthosis nigricans is basically a skin, like a darkening of the skin, which you usually will see in the sides of the neck or at the back of the neck or any area, it could be at your elbow, any pressure areas in the body could develop those. So those are, it's different things can produce that, but it is commonly seen with type 2 diabetes. Remember the adult onset diabetes, which is associated with obesity, with elevated cholesterol levels, with high triglyceride levels. So it's just a sign of insulin resistance going on in the body. And yes, because type 2 diabetes, you can have a family history of type 2 diabetes. So definitely it could run in the family. And but it's pretty much a marker of insulin resistance. Now that being said, it can also be seen in other diseases like some cancer types. But if it's running in the family like that, most likely it is due to insulin resistance and not just acanthosis nigricans or one thing will not get you into the study. I think we need to know if you have diabetes or not, if the blood sugars are elevated and what other associated conditions. And then if yes, you have diabetes and we think it's atypical, which you wouldn't be able to tell. So it'll be best to discuss with a specialist like an endocrinologist. And if they think it's atypical, then absolutely get in touch with the Radiant team and take it from there.
Do we have any other questions? I just wanted to also just kind of reiterate the importance of treatment, because I think, the insulin and glucose monitors and just the insulin needles in general can be very expensive for a family, even with insurance. So the ability to transition from insulin to more of like a pill treatment is also can have a great impact financially and also quality of life of not having to stick yourself every day. So I just wanted to kind of reinforce the importance of, getting that right diagnosis. Well, I have one question myself. There is kind of an interesting thing that can happen with GCK MODY during pregnancy. So if you think about typically if a woman has GCK MODY, she may not necessarily know it until pregnancy. So kind of thinking about that, if a woman comes in and it looks like she has pre or gestational diabetes, are there some things that you can look out for to actually see, actually this might be GCK MODY?
I think that's a very good point that you raised, Liz, that, we do worry about like GCK kind of presentation when they're presenting in adolescence, not fitting the picture of like a type 2 patient. They're not obese. They don't have that typical appearance of a type 2 patient, and especially in pregnancy, which is a state of insulin resistance, right? So it can definitely exacerbate the glucose levels and the presentation. And I think the fact that if they do have GCK mutation or change in that gene, and that is leading to diabetes presentation during pregnancy, it'll happen much before a normal woman is usually screened for diabetes, which is around after 20 weeks. So that presentation will be way before that. I think that'll be one of the important differentiating factors. And then again, it'll be more of the fasting blood sugars that will be affected compared to postprandial. Whereas when you have your typical obese woman or metabolic syndrome related women with type 2 gestational diabetes, they'll have more of both fasting as well as prandial. Those are the two top things that I can think of that will help differentiate.
All right, thank you. All right, so we have another question. So with diabetes being the most expensive chronic condition, have there been innovations or research success in finding alternatives to produce insulin recently?
So I can maybe start this question like I think the short answer, unfortunately, no. But maybe the long answer, there are so many studies going on in different types of diabetes. For example, in type 1 diabetes, the autoimmune diabetes, and there are multiple immunotherapy trials because it is thought that this is a immune system attacking the pancreas. That's why destroying the cells making insulin. And there are several different immunotherapeutic agents have been tried. And then actually there was one, it was shown to delay that process and the type 1 diabetes diagnosis up to 3 years or so. That's one area. And there are some studies on islet cell transplantation and as well as some stem cell. And but as of now, to my knowledge, we have not made a big progress there. I think the more than the patients making their own insulin, we see the main development in the how we deliver the insulin with the technology and with closed loop system, how we can make patients' life better, easier, and within past 5 years, I can tell that like we are in a much different place now than 5 years ago. And then the things will be getting more and more automated, and then the burden on the patients is and families is decreasing significantly. And now we are at the stage that there is a pump which can give insulin as well as the glucagon, which is the opposite of insulin. One is, you can think of maybe gas pedal, the other one is the brake pedal. So then and you have also the monitor that looks at your blood sugar level, and then using an algorithm, and sometimes it gives the insulin, sometimes it gives the glucagon. And then this is not in the clinical practice yet, but there are research studies testing this approach, which may become available in the upcoming years as well.
Okay, great. So there's two questions about a genetic diagnosis. So how do you get genetically diagnosed? So, where to go to get genetic testing? And then if you have a parent that's diagnosed with type 1 or type 2, should they undergo genetic testing if their child is diagnosed with a monogenic form?
Those are good questions. So in terms of getting the genetic diagnosis, you would want to do genetic testing. And so there are very specific laboratories that can take either a blood or a saliva sample and use that to extract your DNA or your genetic information, and then sequence or read the sort of letters of the alphabet within those genes that are associated with monogenic diabetes. And so that genetic testing, I would say in most places, it's probably most often ordered by geneticists or genetic counselors, so sort of usually in the context of a genetics clinic. However, we know that in a lot of like larger medical centers, like here in Houston in the Texas Medical Center, we work with a lot of very genetic savvy endocrinologists like Dr. Gaba and Dr. Tosur, who are very accustomed to also ordering this type of genetic testing. And so I think it depends a little bit when you're working with an endocrinologist or a general internist on what their kind of comfort level is in ordering genetic testing. It sometimes involves a few extra steps to try to convince insurance to cover the testing and some things like that. And occasionally there can be genetic results from that testing that are a little bit uncertain. And what I mean by that is sometimes the laboratory will identify genetic variants, and it's not clear whether those variants are benign or whether they can actually increase a person's risk of diabetes. Most of the genetic changes that we all have are benign, and they're genetic changes that make me, and they make you. So they kind of explain, they're just kind of little differences, but they don't impact our health. So the laboratory's job when they're looking for those differences, even when they're looking for differences in diabetes genes, is to sort out which ones are benign and which ones are what they call pathogenic, or that would increase your risk for diabetes or other health problems. And when they're kind of doing that, occasionally they'll find a variant where they say, This one, we just don't have enough information to say either way, and they'll call it a variant of uncertain significance. And I think a lot of times when someone has that type of a result, they'll find themselves speaking to a geneticist or a genetic counselor about exactly what steps to take and how to manage that. And so not that you have to go to a genetics clinic, but I think from a practical standpoint, a lot of individuals in the United States probably end up going to a geneticist for that type of genetic testing. And then I forgot the rest. Let's see.
So if a parent had, if a parent had type 1 or type 2, should they be tested if their child has monogenic diabetes?
So that's a good question. Yeah. So if your child has monogenic diabetes, there are 3 ways that they could have come by that diagnosis. Well, let me say this. If the monogenic diabetes is what we call autosomal dominant, then it was either inherited from their mother, or it was inherited from their father, or that genetic change was what we call a new mutation that happened right around the time that child was conceived. Not through anything that either parent did wrong or anything that happened during the pregnancy, but when all of us are conceived, there are a certain number of genetic changes that kind of happen for the first time in us. Most of them are benign, but occasionally one of those genetic changes will actually impact how a gene functions. And so those are the 3 options. Most of the time, the variant will have been inherited from one parent or the other. So I would say that if there is a parent that has diabetes, and that child definitely has a monogenic diabetes, and the gene and the genetic change has been identified, it's very straightforward to test that parent for that exact genetic change. It's actually a very focused test. You don't have to look at all of the genes. It's a less costly test also, which insurance companies love to see. And you get a very clear yes or no answer about whether that genetic change came from that parent. It's theoretically possible that the genetic change could also have come from the parent that doesn't have diabetes. So occasionally we'll see people who have a heightened diabetes risk, and you expect them to have monogenic diabetes, but for whatever reason, they either haven't developed the diabetes or no one has looked closely enough to detect it, and it's very, very mild. And so occasionally you can have a parent say, I don't have diabetes, and then you test them for one of these genetic variants that's been identified in their child, and lo and behold, they have the variant. So that can happen as well.
All right, great. And it looks like we're right at time, so perfect timing. Thank you all again for presenting, and we hope our attendees were able to learn a little bit about some monogenic diabetes. So thank you all for coming.